Well, hello everybody, and welcome to our next COVID series webinar from the Royal Society of Medicine. I'm Roger Kirby, and today's special guest is Professor Calum Semple, who is a professor of pediatric respiratory medicine at the Alderhay Hospital in Liverpool. Callum qualified in medicine from the Middlesex Hospital, sadly now closed, Merton College, that hasn't closed, still going, and will do for many years, I'm sure. And Callum is a member of both SAGE and NerveTag. In fact, the reason we're starting a bit early is that Callum has to go at 1 o'clock for another SAGE meeting. So we'll be grilling him a bit about SAGE. But Callum, the reason that we got you on the show is because you appeared on the Today program a couple of weeks ago to talk about your ISARIC study in the Lancet about hospital infections and so on, and risk factors. So let's start with ISARIC. I mean, why does it? What is ISARIC, and why does it keep popping up?
Well, Roger, thank you so much for inviting me to speak to the Royal Society, and it's a real pleasure to do so. I've enjoyed my membership for many, many years. ISARIC is the International Severe Acute Respiratory and Emerging Infection Consortium, born out of deep frustration from the research community, particularly intensivists and infectious disease doctors, and about the frustration that we couldn't mount a research response in the 2009 flu pandemic. And the leadership at the time was Jeremy Farah, Fred Hayden, great intensivists from America, John Marshall, and then a few young whippersnappers such as myself, Kenneth Bailey from the UK. And we thought that next time there's an outbreak, we should have some protocols ready and some permissions ready to do research, so that there wouldn't be this horrendous delay where you have to write a protocol, go to ethics, get a revision. Because what happened in 2009 was, with the exception of Peter Openshaw's study called Mosaic, there was no preclinical research. And with the exception of Jonathan Van Tam's study called COSIN, there was no structured detailed clinical characterization work on the patients. And there was not a single clinical trial conducted in America or Europe on pandemic influenza. So ISARIC set up protocols, we got permissions, and we have activated for cases of monkeypox, MERS, Ebola, SARS coronavirus in Korea and Kingdom of Saudi Arabia. And it meant that on the 17th of January last year, when we recognized cases in Taiwan and Singapore, we activated and were therefore able to recruit the very, very first patients that came into the UK with COVID. So that's what ISARIC is, and it's totally changed the paradigm of how we do outbreak response research.
And who funds it? Because that sounds like an expensive organisation to run.
Well, it's mainly funded by blood, sweat and tears and goodwill. And initially, La Ka-shing Foundation put in some pump priming money, and Wellcome Trust did the same. But that was just money to keep the lights on. Having built this and shown that it was ready, we were fortunate that the MRC and the NIHR recognized the potential of our study to deliver. And we were very generously funded right from the start of this outbreak. But we actually started collecting data and doing our work without any major funding.
Yeah, well, having Jeremy Farah on side, it's got to be a positive. I've just been reading his book Spike, which I recommend to our audience. Fantastic book, full of really interesting things. But let's focus a little bit about the paper and the identification of risk in COVID, because I mean there are a lot of interesting things. Men more susceptible than women, men over the age of 60, I think, etc. So age, sex, comorbidity. Just tell us a little bit about the identification of risk.
So the advantage that this study has is its prospective data collection. We ask research nurses and medical students to collect data on patients as they come through the front door. We automatically collate that information and present it in reports, and build into these automatic processes the statistical analysis and produces charts. So we get data updated at 3:30 in the morning, and it produces a PDF form that we can send into SAGE and NerveTag the next morning. We we're quite surprised to find in UK data a number of risk factors that hadn't been recognised in China, particularly obesity. And that was one of the early surprises. We also showed this striking age and sex risk. We really don't know why it is that men are so much more susceptible. It's independent of the number of comorbidities. It is strictly age and sex related. Ethnicity does have a function to play, but much of the ethnicity issue actually derives to do with comorbidities associated with ethnicity. But we do suspect there may actually be genuine genetic reasons and behind that too. We have been criticised very heavily for genetic determinism as a function of severe disease, but it does appear to hold true that there are either risk factors that we can't properly measure through deprivation and ethnic heritage, which we can't identify through indexes of multiple deprivation and comorbidities. So having ruled out the plausible, we do have to retain the possibility that there are some important polymorphisms or SNPs that are associated with some ethnicities that increase risk. Yeah. But even with other infectious diseases such as meningococcal sepsis, we do see higher rates of poor outcome even in children. So there are sex differences in the immune response and your likelihood to survive infectious diseases. And the bottom line is that women are the stronger sex.
Yeah, it's interesting. And a figure that's been bandied around is that 1/3 of people who died in the first wave of COVID had diabetes. And I suppose that's linked to obesity, type 2 diabetes. I think, is that right? A third diabetes, big risk factor?
The stereotype was a biggish man who was very overweight, and type 2 diabetes was often identified. Frailty, sex, age are the big problems. But now, with vaccination, the big problem is just not being vaccinated.
Yeah.
Our demographic has totally changed. We used to have a very clear inverted pyramid of age risk for death and admission to hospital. Now the demographic chart looks like a column, and there's a bulge which starts at about the age of 50. So the majority, at least half, are under the age of 50, and most of them are not vaccinated.
Mm. And you're a pediatric respiratory expert, and children hardly ever get severe COVID. Is that right? Or do you think
that's right? And I have been asked, what's a pediatrician doing in this game? But we are very lucky. We've looked at wave 1 and wave 2 data. We've seen just over 2,000 admissions to hospital of children in our study, and we represent about 45% of all admissions. So certainly less than 5,000 admissions of children. A population of children in the UK is sitting around about 14 million, and the number of deaths are around the order of 12 deaths, and all but one of these deaths is in a child with profound life-limiting comorbidities. The other death being a subject of coroner's inquiry. Wow. So yes, the risk of severe disease is incredibly low. The risk of the multi-inflammatory syndrome is there, but it's, again, we're not talking tens of thousands, we're talking about hundreds of cases. But it's a nasty disease, a multi-inflammatory syndrome. And many of these children are very, very sick, but on a population basis, nothing near what the adults are experiencing. We don't really know why this is. We suspect it's to do with expression of the angiotensin converting enzyme type 2 protein, which is regulated in the maturing lung. And colleagues in Alderhay and Edinburgh who are looking at immunostaining of developing lung are seeing less ACE2 expression in children, and it gradually increases as you enter puberty. So that may, if the simple lock, viruses use a lock and a key to get into a cell. If the lock just isn't on the cell surface of a developing lung, then the virus just can't get in.
And what about obesity and diabetes? Why does that make one more susceptible to the severe form of COVID?
we should really ask an expert on this, not me, but I suspect it's something to do with the inflammasome and the inflammatory state. Certainly, if you get respiratory distress, then having a lot of weight on your chest makes it difficult to ventilate. But there is something about having high background sugars in your body and a lot of fat that makes your white cells a bit sleepy and may make your body more likely to overreact and have this so-called cytokine dysregulation.
There's a question come through from Nick Wilcox. Thank you, Nick. Is smoking still a risk factor for severe or any form of COVID? He's asking.
Yeah, we've been a bit quiet about smoking because it kind of drops out with all the other things causing greater problems. I'm quite sure smoking is a risk factor, but when you do the statistics, there's just so many other, if you like, the sometimes called a direct acyclical graphs, where you do A causes B causes C causes D. And smoking is one of the early things, without a doubt. But if you're overweight and you've already got lung disease, when you try to do the statistics, you find out that the overweightness and the lung disease swaps the other bit. In the same way that some smokers just get lucky, but if you're a big fat bloke, you're not going to get lucky.
Yeah. So the message is get the weight off, get out there, and change your lifestyle. Yeah.
One of the secrets is actually to stay young forever. I don't know how we do that.
That's tricky. Peter Pan, only Peter Pan does that. Let's talk a little bit about infection in hospital, because that they got you on the Today program to talk about that, because some hospitals have better statistics in terms of infections from COVID. Is that right, Callum?
This was a surprise for us all. Right at the start, we were gathering data, and I was looking at the data returns, and I was thinking that the medical students and nurses were making errors in entering the data, because they kept telling us that symptom onset was occurring after hospital admission, and we were thinking, this can't be right. You can't have your symptom onset after your date of hospital admission. So we went back to them and said, what's going on here? And they said, oh, no, this is correct. These are people that come into hospital for broken legs and strokes and other things. And then they've developed COVID in hospital. And we started looking at the number of days between admission and symptom onset. And we knew what the incubation period of the virus was, a median of 5.1 days. So we said, if it's more than 5 days, chances are you caught it in hospital. And then we started plotting the proportion over time. And we started developing a very worrying trend. We saw this towards the end of March 2020, a very stark rise in the proportion of COVID cases that were actually hospital acquired. And we presented this to SAGE and NHS, and they said, go back, check your data. And we went back and checked the data and came back to them with the same results, but actually we broke it down by regions and individual hospitals. And that's when it got really interesting, because there was a genuine desire within the NHS to understand what was causing variation in these figures. We quickly identified that long-term facilities such as residential mental health units and the old cottage hospitals, because some parts of the country still have them, they had very high rates, and that's understandable because the patients are in there a long time. But even in the acute and general hospitals, we had what I would call unacceptable variation. So we had some very big, busy hospitals which were maintaining their hospital-acquired infection rates around about the 2-3-5% sometimes, and other hospitals just as big and just as busy with very, very much higher rates, 15, sometimes even 20%. And we were able to then share this data with the NHS, and the NHS were able to go to the trusts and start looking at what were the features associated with high rates of transmission and what was best practice. And this wasn't rocket science. When it was looked into, it was straightforward things like availability of PPE, availability of side rooms, general busyness, and adherence to good practice. So it wasn't rocket science, but it was important to discuss. It was presented actually well over a year ago it just took an awful long time to put it into mainstream journalism.
And did any of do they make changes that actually reduced infection rate? Could you show that changing practice actually had an impact in terms of cross infection within hospitals?
What we've seen between waves 1, 2, and 3 is steady improvement throughout all that. So what was a major problem in wave 1 was less of a problem in wave 2, and a much smaller problem in wave 3.
Yeah, yeah. I mean, what do you think was the worst mistake? I mean, there's going to be an inquiry eventually about this, and they'll be looking at all these mistakes. I mean, the most publicized one is sending patients out from hospitals to kind of care homes. And I suppose that would be the number one, do you think, obvious mistake that was made in terms of spreading infection around?
I think that and the lack of testing capacity, which meant that testing was pulled from the community back into hospitals in a way where it was pretty obvious that people had COVID because of the nature of their presentation. So there was less testing in the community for some time. So yes, mistakes were made and recognized, and sending people with COVID into high-risk environments was a mistake, and has been widely recognized as such, yes.
Mm-hmm. Well, listen, and just focusing on the pediatric side of it, because that's where your specialty is there's a question from Dr. Jayarathna, presume he's a doctor, Ridma. Is there any difference in children being infected by the Delta variant compared with the previous Alpha variant? And there are new variants coming along. I mean, it occurred to me that there might be the 1918, 1920 flu epidemic, the epidemiology changed, didn't it, between the different waves, and different age groups were affected differentially. I mean, it would be a horror story if COVID was suddenly found to infect children, especially like today. They're just going back to school today, and this week, many schools. So let's talk about that, the different variants and the different impact on children.
So many things have changed over the 3 waves of the pandemic. Wave 1, effectively society and lockdown. Wave 2, most schools being mostly open, with some parts of society more open. And then wave 3, it's a bit of a free-for-all. So there was many changes in what was going on in the community. Despite that, we haven't seen a change in the overall case fatality rate between wave 1 and 2. We have seen a difference in the age demographic of children being admitted. So fewer older children being admitted, and for mild disease, slightly more babies relative to the older children. But again, the outcomes have remained very positive, and there's been no change in disease severity within those admitted to hospital. So what we're seeing is a change in the confidence within the community to manage mild cases. So mild cases are being managed in the community with greater confidence. We're not seeing increased death rates. We're not seeing increased rates going to intensive care. That's hard data. It's just been submitted for publication. It'll go into a preprint server in the next week or so, and it's gone to ministers for their review too, because it will no doubt play into current decisions by JCVI. Mm. So that's looking at by waves. If you want to look at it by individual virus type, it becomes very, very difficult, because the absolute numbers are relatively small, and not everybody has had the virus fully sequenced. Instead, they used what's called the S gene dropout to identify the alpha, and then the S gene coming back in to identify the delta. It would be a nightmare if this disease started causing problems for younger children. I agree, but yeah, I'll go out and I'll stick my neck out here, and I think this is one that the younger children will most likely not be thumped by, unlike influenza.
Yeah. Well, that gives me an opportunity to give a plug for our meeting on the 22nd of September. We've got Sharon Peacock and Sarah Gilbert from Oxford, the inventor of the AstraZeneca vaccine, as well as Sarah Walker. and it's a 3-hour program from 12:30 to 3:30, and we're talking about vaccines and variants there. So please do sign in for that. But children and vaccines, I mean, they're going back to school. They may not get ill from COVID, but they can spread it around a lot. And that raises the question of whether by vaccinating children, you could reduce the spread. So actually, there's a question here from Lizzie Roberts. She said, you mentioned this morning that you'd recommend just one shot for 12 to 15-year-olds. Can you explain the rationale for offering just one dose rather than two or none at all? So let's talk about that.
Yeah. So, and again, this is definitely me speaking in a personal capacity.
Right. Yeah.
There's really strong data that children are less likely to catch the virus, acquire it. Once they have it, their disease is milder, and they're far less likely to transmit it because they've got fewer symptoms. They're not coughing and snotting to the same degree as the adults. So all things being equal, if you had to compare a university rugby team with a under 12 rugby team, the under 12s are less likely to acquire, transmit, and therefore amplify. But the point we're making this morning is that things are no longer equal. We've vaccinated the majority of adults, and many adult workplaces can work from home or have flexible working or can maintain social distancing, and that cannot be done in schools if you want to maintain normal education. So that's one aspect. So schools, and I've contradicted Yvonne Doyle, who's our Director of Public Health England here, and I would say that schools are now an amplifier of disease, but only because of relative change. But we cannot get away from the fact that there's around about 25,000 schools, about 2,500 or 3,000 of them are secondary schools. So these are workplaces, there are children there, and there will be some amplification going on there because you can't maintain social distancing. As far as the children themselves, what are you protecting them from? Well, you're protecting them from disrupting their education and lack of social development and emotional development. You're not really protecting them from severe disease because they don't get severe disease in the first place. So my point about vaccinating the children that are older, that are more biologically adult, is that this would be to reduce amplification from the one source that is remaining in society, rather than necessarily protecting them from severe disease. But COVID's still a nasty disease. I mean, the kids don't enjoy it. And if people want to make a decision to vaccinate their kids because it's a nasty disease, that's to me seems entirely reasonable. The risk of myocarditis sits at around about 1 in 250,000, and it appears to be more associated with the second dose. So the logic of a one dose only approach is it minimizes the risk of a side effect which is deeply unpleasant. And these kids have got very strong immune systems. If you show them the vaccine once, you will protect them from the disease. You will reduce further the likelihood of spreading it. And you don't need to give them the second dose anyway, because if they meet the virus naturally in the environment, that will give them a live virus boost, much in the same way that live chickenpox gives you a boost to your immunity throughout your adult life. So school teachers and pediatricians are less likely to get shingles because they meet chickenpox in their working environment throughout their professional life. So it's jolly good thing to keep a school child around. But
we're sending our kids back to school without the vaccine, without they're not wearing masks anymore, and they're all gathering there along with their teachers. I mean, do you think that the JVCI have been a bit weedy about this? That they should.
No, I think I would be cautious too if I was reading about the good studies that have been conducted. There are studies from Israel and the American military where they've looked carefully for side effects in a good prospective manner. They've identified myocarditis in young adults, and if you're seeing it, that signal there, you would be sensible to think, well, if we're seeing this in 19 to 23 year olds, then could this be worse in 16 to 18s? Could this be even worse in 12 to 15? So I think they're right to take a cautious.
Yeah.
Right.
Do you want to take a punt on whether they will make that decision?
I honestly don't know. I really have sympathy for them. I think it's very finely balanced. My understanding is the decision process should be first and foremost do no harm, ideally do some benefit to the individual that's taking the risk, and if there is a very strong public health reason, that might sway the argument. But I think you need to look very carefully at who's benefiting within that age group. Yeah. And the arguments would go if a vaccination would give greater confidence to maintaining educational activities, that to me would be a very strong argument.
Yeah.
But there's really good people on this committee that I would trust. I hold the committee in very high regard.
And that answers Janet Amarke's question: is there a case for giving children under 12 pre-puberty the vaccine? Probably there isn't. But which countries have given children? Israel has. Quite a few states in America have given children of school age the vaccine, haven't they? Is that right?
They have, but at least half of Europe has not.
Mm-hmm.
So I don't. It's often very easy to cite, oh, America's done it, therefore we should do it. Well, there's a lot of things that I don't think we want to replicate.
Yeah. And then the other question about vaccinations is the over 80s are desperate to have their booster jab to boost their immunity. And the latest thoughts from the JVCI is that people who are immunosuppressed, I think, can get the third jab, but not the over 80s. What are your feelings about that?
I think they're right, because they get to see the data before I do, but the data I have seen suggests that even with a small reduction in antibody levels, the protection from severe disease is maintained. And the purpose of vaccination is primarily to prevent severe disease.
Mm-hmm.
So there doesn't seem to me to be much point in boosting if you're already protected. It's an unnecessary use of resources. The interesting issue around the immunocompromised group is that the first 2 doses of vaccine haven't worked particularly well. You do tend to get a diminishing return after a number of doses. So although it's worth giving the booster to give an additional percentage protection, you're doing so in the knowledge that it's not ideal. And there is a highly potent monoclonal antibody coming onto the market in the next weeks or months, and to me that would get round the problem of immunosuppressed people's inability to mount an appropriate response, is to instead give them a dose of highly potent immunoglobulin either at the time of presentation of the disease, or if there's a vast amount of it available on a prophylactic basis. But we have to see how much of that drug is available.
Good question from Surinder Paul here. Thank you, Surindra. Do children get long COVID? Because that's going to influence things, isn't it?
That's a great question, and one that we can now answer with a greater degree of confidence, because just yesterday Terence Stevenson from University College London with colleagues, including some ISARIC colleagues and Olivia Swan from Glasgow, put a preprint out, and it's again a really good study, properly controlled study, and I'm going to try and remember all the data now. They found at 3 months after a positive test, they looked at symptoms in test negative children and test positive children 3 months later, and they were surprised to see that problems such as fatigue and sore throat and headache were actually remarkably common even in the apparently normal healthy population that were test negative. But they found roughly a 14% excess 3 months later in those that were test positive. So long COVID in children does exist. It increases headache, fatigue, and difficulty in breathing. So it is a real phenomena. It doesn't occur with nearly as much frequency as was supposed from social media and lobbying networks. It looks to be more like 1 in 7 of the children that are tested positive are at risk. So it's certainly not half the children that are infected. One in 7 appears to be a more likely number. Interestingly, they also looked at the mental health and well-being and found no effect of test positivity on mental health and well-being. Instead, identifying that actually COVID had actually made a lot of children the COVID nationally had made children pretty miserable, and lethargy amongst teenagers appears to be a fairly normal state for some of them as well, which I think those of us that got teenage children probably realise. So Terence's data is really very reassuring. Certainly long COVID is real, but it's not as big a problem as we thought. The problems that headache, fatigue, and difficulty in breathing are not new problems. Pediatricians deal with these things. So there are treatments. They're not instant cures, but they can be managed. Children can be rehabilitated, and they can certainly get back to school.
Great. I want to come on and grill you a bit about SAGE, because we've had lots of SAGE members on this, but none of them have told us what SAGE actually does. But before that, there's one question which I think is going to be helpful to get an answer from you. It's about Antivaxx, which is a big problem, growing problem worldwide. As you know, most of our staff who have vaccine hesitancy seem to relate that to concern with fertility. Is there any evidence at all to reassure them, and how can we address that as a form of women are very obviously concerned that somehow the vaccine can affect fertility. Where does this come from? Is there any truth in it?
There's no truth in it at all, and it's understandable for any new medicine when there's inadequate early data. But a lot of women were vaccinated before they knew they were pregnant, and there are studies that went on that recruited pregnant women through by default. So safety data has gradually emerged, and now there is confidence that it doesn't affect fertility. So I think we are, now that we're many months into it and a good year's worth of trial data, there should be greater confidence that this is not a drug that affects fertility. The problem with the anti-vaccination, it is a very fixed mindset, and I find it very difficult to persuade people. I think it's probably wrong to expect so-called experts to do the persuading. I think we live in a society where we allow people to make bad decisions. It's much better to show influencers who've made good decisions and who are much better at influencing than we are. So I think it's going to come down to our Love Island contestants or our I'm a Celebrity, Get Me Out of Here contestants who've lost a parent or got a brother with leukemia or a daughter with cerebral palsy, who they say, look, I've had the vaccine because I wanted to protect my dad or my brother, my daughter, my cousin. I'm fine, and here's a picture of my bouncing twins.
Yeah,
that's a much better story than me with my spectacles and my somber-looking study pontificating. I think we should move away from the old way of doctor knows best. And
you've been targeted by the anti-vax group, haven't you? Didn't somebody post something along the lines that Callum kills wildlife for fun and lives in?
That's right. Yes, a number of statements have come under have attracted adverse attention, and we are fortunate that the police are open to hearing from us, and there's good liaison support for us when these threats are made. That was one particularly nasty event. There have been others since then, and some suspicious packages sent to SAGE members and myself. And this comes from both extremes, people that feel that we're making bad decisions, and they don't appreciate that SAGE is not a decision-making body. We instead take essentially exam questions from ministers or from chief scientific officers or chief medical officers who will say, could you tell us what the most likely impact of X is versus Y? And the modelers will try and give a best estimate. Or they might ask someone like me, what's the effect of case fatality amongst children in wave 1 versus wave 2? And then we present that data back, and the chief medical officer and the chief scientific officer take that data, and then they present it to ministers. I've never been at a SAGE meeting where we've sat around drinking coffee saying, wouldn't it be a jolly good idea if we close the pubs? That conversation has never and will never happen. It's about what is the likely contribution of construction versus schools versus large matches, and that's where you can then present a menu of likely impacts, and then it's for policymakers to make the decisions. But we're not a talking shop, or we're not a suggestion box or a brains trust. It's very much about dealing with inadequate information and giving best opinion.
Well, in 8 minutes' time, and I'm going to let you go precisely at 1 o'clock, you've got to join the SAGE group. So tell us, I mean, how well has it worked? Of all the things that have and haven't worked in during this pandemic, how well has SAGE worked?
I'm very biased. I think it works very well because it's got a very broad church of advisors. We do have access to coronavirus virologists. We've got access to engineering experts who really do understand how air moves and how viruses behave in air. The criticisms against the modelers, I think, are outrageous. To be sure, at the start of the outbreak, we had one model based on flu, which had the R value and the doubling interval plugged into it from the most recent data available, but that was quickly recognized as being wrong. And when the model had the right data put into it, the model behaved very well. And then the next thing that happened with the models was they diversified to, rather than having one group providing one model, they had 7 modeling groups from 7 universities. And for any particular scenario, they would typically look at all the models, exclude 2 outliers, and take the median forecast for the 5 remaining. And that gives a very good, a much better model. All models are wrong. It's just some are useful. It's what they tell us.
Yeah.
And then these models are not long range forecasts. They say this is what would happen based on what's happened in the last 3 weeks. And if you do something different today, we can tell that it's going to take 17 days before you get an impact on hospital cases, and it's going to take another 11 days before it has an impact on mortality. Therefore, if you have a model showing a curve going up and exponential, you can say with great confidence, no matter what you do today, things are still going to be an awful lot worse in 23 days' time, because we know that that's baked into the system. And I think it took some of our policymakers some time to understand that process, but they understand it now.
Mm-hmm. Heidi Eagles just posted a question. Experts advise ministers decide. I think what she's trying to ask is, do the ministers make the right decisions? Have they made the right decisions? Or do you find that as a SAGE member, you're frustrated by the delay in some of the decisions, particularly in the second wave before Christmas, the delay in closing things down again, for example?
I think the Westminster answer is, you might think that I couldn't possibly comment. No, that was House of Cards. There's inevitably some frustration, but we understand that they have to take into consideration wider choices about the effect on the economy, effect on national security. They've got a lot to take on board as well, and I think scientists, the good scientists, appreciate that these are bigger decisions than simply based on what the science of the day is. Where we did cry foul on the 30th of May last year was when ministers said they were following the science when they absolutely were not. And the independent members of SAGE, without conferring, I must stress we didn't confer, but 4 of us stood up and publicly said, no, you are not following the science, and you may not rely on our reputation to say that your decisions today were based on our advice. And that led to quite a kerfuffle. A few of us were taken aside and said, you really shouldn't be saying these things. And we said, sorry, we absolutely must say these things because we're independent members, we're not civil servants, we're not paid by you. And if you want our advice, you must represent our advice fairly. You cannot say you're relying on our advice when you're not.
Yeah. Yeah.
You should instead say we've taken scientific advice, but in the round and with greater consideration for other factors, this is the decision. And
Mhm.
that was a very hard couple of weeks for us all professionally.
Mhm.
But we do work with a. Since then, there's been a far greater degree of mutual respect.
Yeah. Well, I can see just behind your right shoulder, there's a set of bagpipes, Callum.
Yes.
Tell us a little bit about you, because you've lived through lots of pandemics, haven't you? You were HIV, you've done Ebola, you did the flu epidemics at the turn of the millennium, and now you play the bagpipes.
I've played the bagpipes since I was a little boy. The Glasgow Police did an outreach program. They taught us for free, and
Right.
I quite enjoyed it. It's been really good for my health and well-being to be able to go away and just focus on playing some music for a while. I've had 2 weeks in Scotland, and I learned 3 bagpipe tunes while I was away, which is great fun. The pipes have gone with me to Uzbekistan, Sierra Leone, places where I've done outbreak investigation work, and they are a great icebreaker. Did cause a security alert in Uzbekistan, and then ended up in a fight between the immigration guards and the interior security guards had a fight because one lot wanted me to play the pipes and the other lot didn't. They're a great source of fun. I love playing them, and they go with me in many places.
And how scary was the Ebola pandemic? I mean, you were down in Sierra Leone at a time when people were dying, and there were,
Yeah,
I
yeah.
guess, all sorts of issues there, right?
November 2014 was awful. We did see, as we were driving through Freetown, we'd see bodies in the street and people pointing and not knowing quite what to do. We benefited from the British military providing a security presence, and that really helped us get on with the work and was very, very valuable.
Did any healthcare workers actually get Ebola themselves, or did
But
you?
many. I've got a photograph of a wall from the Connaught Hospital where they posted pictures of the nurses and doctors that had died. And when I was having our protocol discussed by an ethical review committee that I was sitting in on, a note was passed to the secretary and then passed to the chairman, and he read it out in front of everyone, and he said, "It's with great regret I have to tell you that our colleague has died." And thank you very, very much.
Lunch has arrived. Yeah.
It's just very kindly brought me lunch because she knows I'm going into Sage.
Hey, look, Callum, you've got to go. We got 1 minute. I wanted to ask you, crystal ball for the future. Are we going to face a fourth wave? What's this winter going to be like?
Crystal ball time. I think we are in the middle of a third wave. I think it's going to be a miserable winter because we're going to see the other respiratory viruses come back. We're already seeing a surge of parainfluenza virus and respiratory syncytial virus in the kids, so the pediatric wards are busy. The adult intensive care units in the north of England are very busy at the moment, mostly with younger adults that are not vaccinated or not fully immunized. And the problem there is that they're salvageable, and they spend a lot longer on the intensive care unit because they're salvageable, and that's putting pressure on other services as well. So this virus is here to stay. I do believe vaccination is in general the way out of it. I think we do need to go back to some of the Edwardian traditions of high window openers in schools to improve ventilation. I would like us to stop spitting in the streets. A degree of social distancing. I think the plastic partitions at the tills will be here to stay for some time, and particularly for taxi drivers again. They're at very high risk of catching the virus in the community. So I do think we have to change some of our behaviour and reduce the risk of transmission.
Callum, I better let you go. In fact, you can go because I've got a couple of announcements to make. So you disappear and do your Sage stuff. Thank you so much. I mean, unfortunately, we ran out of time because there's so many other things we could have talked about, but that's great communication. People are asking where they could get the data about the hospital-acquired infections. Is that in the Lancet paper, or?
It is in the Lancet, and it should be open. It should be open access. It's a nice short research report, and it's in the Lancet, and it makes a rather depressing reading. But the original documents were shared with SAGE in I think it was the 1st of April. SAGE evidence, government evidence. You can find it all in there.
Great. Okay, off you go. Enjoy SAGE, and thank you so much, Callum. So thank you, everybody who's tuned in. I'm sorry we started a bit early. Some of you may have missed the first quarter of an hour because of that. Really, the major plug I wanted to make now is on the 22nd of September, we've got a 3-hour focus on vaccines, variants, and infections. Unfortunately, you have to pay a small amount for it, about £30. I think we've got Professor Sarah Walker, Chief Investigator for the COVID survey. We've got Sharon Peacock, famous professor of virology from Cambridge, Sarah Gilbert, inventor of the AstraZeneca virus, and Peter Openshaw, who's often on Newsnight and the Today program and so on, as well as some others talking over that 3-hour period. So do sign up for that. We'd love it if you would join us. I'm also involved in Conversation Live Wednesday evenings at 7 o'clock. We've got Lord David Pryor of Brampton, chairman of NHS England and chairman of University College Hospital London. Here he is. We've got a flyer for him. David Pryor in Conversation on Wednesday evening. So do listen to that. That's free. The vaccine variant and infection you do have to pay for, but it's only a small amount. So thank you, all of you, for listening in, tuning in. We do appreciate your support for the RSM. If you feel like making a donation to help us keep going through the pandemic, we would love that. If you're not a member of the RSM already, please do join. It's a wonderful family of not just doctors, but all healthcare professionals are welcome. So have a great afternoon, everybody. It's been fun talking to Callum, and I hope you've enjoyed the show. Bye for now.